Okay, so we're going to talk about metabolic alkalosis, and this occurs when we have a high pH and a high bicarb within our ABGs. So let's take a look at the metabolic alkalosis model. So when we have that normal homeostasis, we have that normal pH of 7.35 to 7.45. I'm going to keep repeating that so it helps you guys remember that. So we have 7.35 to 7.45 is normal. When we have metabolic alkalosis, there is a disruption and our hydrogen ion level is going to decrease because of a loss, or our bicarb is going to increase because of a gain of some sort. Now, what this ends up with is our pH rises to above that 7.45. And this is because the hydrogen levels have decreased, whether we've lost that hydrogen or whether or not that ratio has just been altered because of an increase in that bicarb, and we'll get into why those things might happen in just a little bit. Now, we have those buffering systems that are going to be activated, and when we have metabolic alkalosis, the buffering systems that are going to happen are those components are going to release hydrogen, and that's to try to compensate for that loss of hydrogen ions. The respiratory system will actually become depressed, and the respirations and the depth and rate are going to decrease because our body is trying to hold on to that CO2 so it can make that carbonic acid. And if the kidneys are functioning, then they're going to begin to try and excrete more of that bicarb. They're going to try to get it out in the urine, and it's going to try to help generate or hold on to some of those hydrogen ions. So this will hopefully return the body back to that normal homeostasis with a pH of 7.35 to 7.45. So let's take a look at some of the reasons that metabolic alkalosis actually occurs. So it can occur when we have an excess of bicarb or the excessive loss of acid. And this interferes with that acid to base ratio, that 1 to 20 ratio that we've talked about. So a loss of gastric secretions that happen through excessive vomiting or through excessive kidney excretion, and even when the hydrogen ions are shifted from that extracellular fluid into the ICF or the intracellular fluid, like in hypokalemia, we end up with this metabolic alkalosis. So let's take this a little bit further, and I'm going to hopefully help you understand this. So with vomiting or gastric suctioning, you're emptying the contents of the stomach, and the stomach contains large amounts of that hydrochloric acid, and we need that again to break down our food. So when we remove that, we're removing both the hydrogen ions and the chloride, and now those two things are in deficit. So remember, the chloride is that major anion that's in that extracellular fluid. So if we take away not only those hydrogens, but also that chloride from the stomach, we now have a chloride deficit in our extracellular fluid. And when it takes a hit, the next major anion is, you got it, bicarb. So to maintain that positive-negative charge balance within the extracellular fluid, our bicarb has to increase, and that's because of that chloride loss. This is going to further that alkalotic state. So when we have a gain of bicarb, this also can happen when we are doing things like ingesting things that are high in bicarbonate, like antacids or Alka-Seltzer. So if you think about it, bicarbonate, go look in your pantry. If you have baking soda, look and see what it actually is made of. It is bicarbonate. So anything that is going to contain that's going to help suppress the acids in some way, like antacids or Alka-Seltzers, we're going to increase our bicarbonate. And so by doing that, we could become in this metabolic alkalosis state. So also, like we've already said, imbalances in our potassium or hypokalemia can actually cause the kidneys to respond by holding on to that potassium, but then they're going to begin to excrete those other hydrogen ions. So because they are excreting those other hydrogen ions, it's hoping to increase the potassium. Now, another way that this works is on the cellular level. In response to that hypokalemia, we're going to shift those hydrogen ions into the cell because our potassium ions are going to shift into the extracellular fluid or out of the cell, trying to compensate for that hypokalemia. So we've lost our hydrogen ions to a shift. They just simply shifted into the cells. Now, the compensatory mechanisms that are going to kick in. We've got our respiratory system that's going to compensate, and it's going to try and depress the rate of inspiration by attempting to hold on to that CO2. And this is going to help because remember that that CO2 turns into that carbonic acid. So it's trying to compensate for the changes in bicarb. Our renal system, if it's functioning properly, is going to start to excrete that bicarb in an attempt to get it back within those normal ranges. Now, how are we going to diagnose this? Again, we're going to look at our ABGs, and with metabolic alkalosis, we're going to start with our pH being elevated. So it's going to be higher than that normal 7.45. So we're going to be above 7.45, as well as our bicarb is also going to be high because remember, metabolic equals. So if the pH rises, then our bicarb is going to rise in metabolic alkalosis. So our bicarb is going to be greater than 26. So we need to understand that that's what's causing this metabolic alkalosis, but it is only a symptom. It is not the cause of it. So we've got to start monitoring and diagnosing some of the causes. So we're going to look for those electrolyte imbalances, like we just said, changes in our chloride. If we have low chloride, whether that was from vomiting or that gastric suctioning, we know that that bicarb is replacing that chloride in the extracellular fluid, so we've had this increase of bicarb because of the low chloride. We also are going to see it in that hypokalemia like we just talked about, and this is because we've had that low potassium. Our kidneys are retaining that potassium, but our body is getting rid of the rest of those hydrogen ions. It's also shifting those hydrogen ions into the cells and shifting the potassium into that extracellular fluid to try to correct that low potassium. So we need to be aware if electrolytes are what are causing that, because we can actually treat that one a little bit differently. So also remember that with any of this hypokalemia, we may also see a low urine pH. So this has to do with, remember, if our pH is lower, it's more acidic. So if we're getting rid of all of those hydrogen ions in our urine, then our pH of our urine is going to be very low because it's going to be very acidic, because our blood is alkalotic. Our urine is acidic. Then we have, we need to keep a monitor on our ECGs. Remember, that's because we have changes with dysrhythmias and all of those things that happen both with low potassium but also with hypocalcemia, which also can be affected because of our low potassium. And what happens is that the calcium begins to combine with that serum protein, and so we have that metabolic alkalosis where we see some changes with our ECGs. Now we also need to be assessing for that fluid volume deficit. Like I just said, that they may have that vomiting, so we may not have the fluid volume that we normally would, so we need to make sure that we are assessing for any of those signs and symptoms associated with fluid volume deficit. Now, Our key things and signs and symptoms that we're going to be looking for. Like I've already mentioned, hypocalcemia and hypokalemia. So think signs and symptoms that are related to these two things. So we've got confusion, we've got dysrhythmias, we've got hypotension that could have been affected by that fluid volume deficit. We've got hyperreflexia, tetany, muscle spasms. Remember, those are related to that hypocalcemia. Those positive Shavach signs, positive Trousseau signs, those things can be seen with with metabolic alkalosis because they are hypokalemic. So we need to be monitoring for those things. We also may have our patients develop some hypoxemia. So we said that their respiratory center is going to be depressed. So they're not going to be taking as many breaths. They're trying to hold on to that CO2, but a result of that could be this hypoxia. And that's simply because they don't have that gas exchange like they normally would, so they're at an increased risk for impaired gas exchange. Some of the signs and symptoms of hypoxia are going to include cyanosis, especially around the mouth and our oral mucous membranes. So we need to be monitoring for those. And then the last one that we're going to hone in on is that vomiting or even gastric suctioning, and I'm going to repeat this 100 times. It's the one that's going to be classic, and it's because our patients are emptying those stomach contents, and that's where we have that hydrochloric acid. So we've taken away all of that acid in the stomach, and now we don't have it in the body. So we have a higher base in the body or higher bicarb in the body simply because of that vomiting or that gastric suctioning from the stomach. How are we going to treat this? Again, just like any of our other acid-base imbalances, the treatment is going to focus on the underlying cause. So if it's potassium, we're going to treat it like we would low potassium. We are going to correct that imbalance, whether that is giving IV potassium or PO potassium, whatever the case may be. We're going to replace that potassium because we want to correct that alkalosis. If we have a fluid volume deficit, or maybe we've got that low chloride, we need to understand that, again, that could be from that vomiting. Could be, we're going to need to treat that with antiemetics or anti-nausea medication, and we also are going to have to replace that fluid volume that was lost. So we're going to be giving fluids that are going to replace that fluid loss. Because we've seen that respiratory suppression, we may be giving supplemental oxygen. And this is because we want to prevent that hypoxemia that we just talked about. So because we know that the respiratory system is going to be depressed, we have that impaired gas exchange, we may be putting oxygen on this patient and giving them supplemental oxygen to prevent that hypoxemia. And then we also may be trying to position our patients in a semi-Fowler's position or a Fowler's position so that that can aid with that gas exchange. And those are going to be the treatments that we are going to most commonly see. So in review of metabolic alkalosis, we see that the pH is going to rise. It's going to be above 7.45, and that's because of the loss of acids or the increase of bicarb if we were ingesting those. Our PCO2 is going to be normal. This is not a respiratory problem, so we are not going to see changes in that PCO2 unless we see it with the compensation in just a minute. So just metabolic alkalosis, our PCO2 is going to be 35 to 45 within that normal range. But our bicarb is what is going to be high. And remember, if our pH is high, metabolic, our bicarb is going to be equally high. So it's also going to rise. So we're going to see that its pH is going to be, the bicarb is going to be above 26. And that is what indicates that it was a metabolic problem. So we had a normal PCO2, but we had a rise in our bicarb, so it's a metabolic problem. Now, as the respiratory system kicks in to compensate, we're going to see that PCO2 also rise because our body is trying to hold on to that CO2. So we're going to see an increase in our ABGs. just like we had that rise in the bicarb. And remember, it's trying to bring it back to that 1:20 ratio of our acid to our base. This in turn is going to lower the pH back to that normal range of 7.35 to 7.45 when we are completely compensated. So we have that normal pH again, but we have the high PaCO2 or high carbon dioxide, as well as that high bicarb in the compensated state. Remember though, partial compensation can occur, and this is just when it's in the process of compensating, but we've not completed that compensation, so our pH is going to be slightly elevated still, and we're going to see that that PCO2 is either going to be almost elevated or completely elevated, as well as that bicarb being elevated, and that's going to be that partial compensation. So again, we're going to work these problems on the live blackboard. If you have any questions, please make sure that you write them down so I can answer any of those questions in our live session.